Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. Welcome back to the Dusty Muffins, your favorite podcast where three menopause specialists armed with research, real talk, and solid appreciation for the pelvic floor health break down the hottest topics in midlife and sexual wellness.
And today we're giving you a full access pass to ISSWSH 2025. That's the International Society for the Study of Women's Sexual Health, where the brightest minds in sexual health gathered to share cutting-edge research, clinical pearls, and some seriously jaw-dropping insights on everything from pelvic exams and painful sex to testosterone, hypoactive sexual desire disorder, vaginal estrogen, and the future of sexual medicine.
We sat through all the lectures, took all the notes, and now we're bringing you the ultimate recap so you get the highlights without having to sit through days of PowerPoint slides.
Today's episode is titled Sex, Science, and the ISSWSH 2025 Deep Dive. Everything you need to know. Buckle up. This one's going to be juicy. What a week, Rebbecca. Oh my God. What a whirlwind.
I don't even think that I am recovered from that. And so, by the way, we're missing one of our muffins because she's doing amazing, amazing lectures. I think actually preparing for 2 menopause lectures that she's advocating and educating women. So we're going to try and keep everything together, just the two of us, while we miss our third amiga. And
we do. We miss you, C. We miss you and your Dusty Muffin.
We miss it. Absolutely. But yeah, Atlanta was amazing. It was a whirlwind. I don't think I was expecting to sit all day with educate. It really was drinking through from a fire hydrant. I mean, it was so much information all day long. I give it to, and not just education, but research and the vendors there. And I mean, we just did not get a break. By the time dinner came, we were done. Exhausted. It was like, no more sex for me.
You know what the problem was? Because when I've been to conferences in the past and you look at the schedule, you're like, yeah, I definitely want to see that one. Definitely want to go to that one. Nope. Yes, nope. I'll go to the gym there. I'll go for a walk there. I'll go get something to eat there. But when you looked at this agenda, I was like, yep. Okay, skip lunch. Okay, yep.
There was no bathroom breaks. No.
You didn't want to miss anything.
No.
Every time I took a bathroom break, I recorded it on my phone. Like I left my phone at the table beside you and put it on voice recorder so that I wouldn't miss anything.
I know. And like, we're sorry. We 100% were like the worst at putting anything on Instagram because we legitimately were in class and learning all of this stuff like all day long.
I know. So. We had the best plans. We were going to do a live podcast. Mm-hmm. We were going to interview people. We were going to give updates on interesting talk we've been to that.
You were like,
oh my God.
So
let's talk about the other thing that was the problem. We couldn't sleep.
No. Okay. So we were perimenopausally cycling together, the three of us. It was insane.
It was
every
crazy.
Morning. Did you sleep? Nope, I didn't sleep. Palpitations, hot flashes, night sweats, tossing, turning.
Oh my God, it was the worst. That every night I'd be lying in the bed, shaking with the cold. I was so cold. And then a couple of hours later, I would wake up drenched in sweat. And then like move over to the other side of the bed, wake up a couple of hours, same thing, get up, have a shower, and then come down for 7 a.m. lectures.
Yeah. Yeah. And I was just like, what is going on here? Is something, what did they put in the water? What did they put here? And, is there like a heating pad underneath the mattress?
I wonder,
I
was
was
it
like,
something on the mattress that was just
I don't
blocking
know.
airflow and all of our heat? Because that's what it felt to me. It felt
Yeah.
like I was lying on the surface of the sun when I woke up.
Yeah.
Well, it didn't
Yeah.
even feel like it was my body that was hot. It
I
felt like it was the
agree.
mattress.
I agree. And it was back to like almost before starting hormones. It was insane.
Yes,
All
exactly.
three of
So
us, which was even more crazy.
I
So if you
know.
can imagine, we're sleep deprived, then in class all day long. We don't know if our asses are coming or going half the time.
We were a mess. And so thankfully, they actually gave us the handouts so that we were able to
Mhm.
go through them afterwards. And now the actual videos, or at least the
Yes.
audios of the talks, are up. So we can actually listen to them on our
Yep.
commute and exercising and walking and stuff, which is
Yeah.
good.
Which is nice because it's so much information that it's nice that when they're recorded, I always like to go back because ultimately I've missed something
Mm,
that, or if it's something that I don't know a lot about and it's the first time I've learned about it, then to re-listen to it 2 or 3 times is nice.
oh, I agree. Nothing for me goes in the first time. I think I'm panicking so much trying to remember everything that I actually space out a bit and
Yeah.
realize I haven't been listening for the last 30 seconds because
Yes.
I've been thinking I have to remember all of this.
I
I have to keep
know.
reminding myself it doesn't disappear after you listen to it the first time. You
I
can go back
know.
over it.
I know. I know. I think we were so worried about all of that. And it was just like poof, poof.
Yeah.
And then something would come up and I'm like, what did they just say? I missed it.
I
I was
know.
looking, but I was gone.
I know. I feel like that when we go to Cirque du Soleil shows. I'm so busy. I'm like I just don't know what to look at, like, because you're going to
Because
miss 10
everything's
other
there.
things.
Yeah.
Exactly.
Yeah.
So
And
you
they
made us this.
were,
Oh,
oh, yeah.
sorry.
Yeah. I was going to say they were quick lectures. I mean, they were like 45
Yeah.
minutes to an hour and they were zooming through the information because there's just so much information. So,
Yeah, and sometimes those hour lectures were broken up into 3 20-minute
yes.
talks.
Yes.
So there was just a lot. You're right. It was like drinking from a fire hose. But you
Yeah.
made us this beautiful kind of agenda to go through today for our podcast where you put in the different talks and the kind of
Yeah.
key takeaways. So we have something to go by today, which is so lovely.
Yeah, it's great. And it's by far, we don't mean to miss anybody
Mm,
or any lecture. So this was just kind of like our bigger points, but there was, so much out there. So if we didn't get to something at some point, we'll bring it back up in different podcasts if we miss something and we're like, oh yeah,
exactly.
this part's important. So,
Exactly.
so do you want to go through the segment number one, or do you want me to start with that first one?
Um, yeah, I'll start.
Okay.
The first one was Rethinking Pelvic Exams by Dr. Sarah Signa, who's a big part of ISSWSH now, and she's just amazing. An OBGYN doctor who is such an advocate for women and for education of clinicians as well. That's
Mhm.
really, you can tell that's her passion, can't you?
Yeah. Yeah.
Um, and, one thing that she did this week, herself and her fellow, they teamed up with a group called hormonally.org and they released the most beautiful visual representations of the vulva and the
Oh,
pelvic
I did see that. I didn't
floor.
realize that was her. Okay.
Yeah. So they put that together. It's
Oh,
beautiful.
that's
It's
awesome.
colored.
Mhm.
So many of us and our patients were never taught what the vulva looks like, the different parts of it. Is it
Yes, and that's the
hormonally
outside,
sensitive?
everyone.
The
For
outside.
everyone
Yeah.
wondering what that is, that's everything you can see on the outside. The vagina is on the inside. We can't see that
Yeah.
without a speculum.
I think we call everything the vagina, and it's not. The
Yes.
vagina is
Cor
internal. That's what you can
Mhm.
see when you put in the speculum. But nobody knows about the vulva, which is so hormonally sensitive and really suffers when we have a change in our hormones, right? Like pregnancy or breastfeeding or on the
Mhm.
birth control pill or menopause.
Yep.
Um, and so her first talk was about rethinking pelvic exams, and how so many women have medical trauma from having had bad experiences with
Yes.
pelvic
With
exams.
just pelvic exams. Yeah. You know, I agree. It's
It's
these are things
amazing
that
how something like
yes.
that can stick with you forever and color how you feel about going to have your pap smear every time you have to go in.
Yes, yes. When you get someone that is doing such an important exam, number one, those are really important. Those are the ways that we, screen for cervical cancer, and the way that we can look inside the vagina in case there are, vaginal, well, and the vulva on the outside too, looking for cancer, but also vaginally, or polyps coming out of the cervix, or
Mm,
any other mass,
mm.
So these are important screening tools, and to have, a clinician that is not sensitive to a sensitive area, and not be mindful of what they're doing, it's too bad, because
Yeah.
it does leave trauma for patients.
Yeah. And, there's conditions that we can have that really make it difficult for us to tolerate a pelvic exam.
Hmm.
Um, Vaginismus is one where the muscles around the vulva and the vagina have difficulty relaxing and can make a speculum exam or even a digital exam with a finger
Hmm.
very uncomfortable. Vulvodynia is where it's exquisitely painful for women when they are touched on the around in certain areas of the vulva. And so if you are kind of on this conveyor belt, sometimes like we feel like we are in the doctor's office, and your doctor comes in and whips out the speculum, and doesn't give you much warning, there isn't much kind of talk about mindfulness, that can really affect you. And then you also have women who've had trauma in the past, sexual
Yep.
trauma,
Yep.
that you have to be educated about and mindful of too. So that was a really good lecture. She was saying, to focus on consent and autonomy, like to talk with your patient about what's going to happen. Don't get them to get undressed before you talk to them, so that
Hmm.
there isn't that power differential as much. They're in their clothes, you're two people chatting, and then you leave the room and allow them to get undressed. And then you come into the exam, and they've consented to it, and they feel like they have more control over the situation.
Hmm. Yep.
Um, she was saying the speculum placement is important as well. Sometimes even the patient will feel more comfortable if you give them the speculum and let them insert
Hmm.
it.
Yep. Yep, I like that, because I've seen that happen even with the transvaginal ultrasounds.
Yes.
Um, that the ultrasound technician will have the patient insert the wand.
Yeah, I know. And it does give you that little feeling of having a bit
Hmm.
more control over the situation,
Yep.
doesn't it? Because I don't
Yep.
know about you, but I find as a doctor, I find it very frightening to be on the other side of all this. I find it very frightening to be the patient. And half of me wonders, is that what makes some of us want to be doctors? To feel like we have
Yes.
control over these
I
situations.
know. I still get all sweaty, and like my heart
Yeah.
races. I'm just like, I've had a million of these. I've had 5 babies.
Yeah.
Like, this should
I
not be a
still
big
fold up
deal.
my underwear and hide them in the
No,
folds
me
of my
too.
pants folded
I
on the chair.
know. I think about that all the time. I'm like, why am I hiding undergarments
I
when I
know.
am having this type of
I
thing?
know.
But that
I
is,
still apologize for not having
yeah,
been waxed recently or
yep,
whatever. When I
exactly.
know
I
in
do
my
every
head,
time.
that's
Every
crazy.
time. I know. And it's funny because I do the same thing, but I have my patients do the same thing. And I'm like,
Yeah.
it does not matter to me. I'm not thinking about any of these
Yeah.
things,
I know.
and I have to talk myself into relaxing, just like we tell our patients, and I think that's one thing that kind of she was saying too. Like, I never just go in, especially if it's a first time pelvic exam, always talk through it first, always show
Mm,
the speculum, always show that there's different sizes,
mm,
and getting in the habit of asking your patient, what size should we use? They will
mm,
probably tell you that they've never been asked before, and
mm.
that they never knew that there were different sizes. And so I ask my patients, because I'm like, I'm not going to remember in 3 years or whenever I see you back
Mm.
what size. So make sure you let me know, or let my medical assistant know, or whatever, and let
Yeah.
them know that there are separate different sizes.
And even at the conference, there were some vendor tables. There was one in particular where she actually makes her own, I think they were silicone maybe,
Yeah.
um, kind of models. And there was one that you could actually put a speculum into. And so
Yeah.
you could actually show your patient what's going to happen,
Yes.
which I
That
think
was
is
really
so
neat.
lovely as well. Yeah.
Yes.
And then she was saying that mirrors are a game changer as well. To give your
Yep.
patient a cheap mirror that you bought in the supermarket with a handle and they can put it down, they can watch what you're doing. And for a lot of women, that takes away some more fear,
Yes.
and and that feeling of loss of control. And then, the last thing really she was saying was that when we're doing procedures like inserting an IUD, to really go through it with the patient and ask them what would they like for pain control. We don't do things to men without making sure we control their discomfort and their pain really well. But we expect women to, my God, clench their teeth and get through the most horrific things.
Yeah.
These colposcopies and endometrial biopsies. I mean, and some of us who have gone through the birthing process have had very traumatic births. And, there's no way you're getting near my cervix without giving me some pain medicine.
A little something.
Yeah,
laughing
exactly.
gas.
So like we always say, like every woman is so nuanced. Every case is so nuanced. But unfortunately what happens in our world is with insurance-based care, we don't have time,
No.
You've got 10, 15 minutes.
Yep. You don't even have time really to walk in there to have a conversation before they're getting undressed,
Exactly.
But I think that there are ways, if that is something that you cannot do, I think there are ways, however, to keep your patients, whether it's an extra gown to go over the front until you're ready to do a breast exam, there are ways to make them feel comfortable, make sure that you're giving them, all of the things that are covering them up as much as possible to keep them comfortable.
Yeah, because I don't know any doctor, thankfully, who wouldn't want to do everything that we've just spoken about.
Yep.
They would do all of that and
100%.
more, but they are being forced to see X number of patients a day just to keep their doors open. And they can either do that or they can leave.
That's right.
And those are your
5 minutes.
two choices. Yeah. And so when we're talking like this, we're talking idealistically, or if you have a private practice that works outside the insurance model. But
we understand that this
let's be realistic. Yeah.
Yep. And I did the last thing on that, and I couldn't remember if it was one of her lectures, because she did a couple, was you don't have to lay all the way back.
Yes, that's right. I love that.
Yeah. I'm like,
sit up a bit.
You're right.
See everything that's happening.
Yeah, let's have a chit chat. Let's have a talk. You don't have to be looking up at the ceiling, counting the tiles, or, in my GYN, he's got some kind of something going on up there that I'm always like, what's up there this time?
What I really don't like, and has happened to me quite a few times, is when there is an assistant in the room, like a medical assistant, and they position themselves behind the doctor, looking over the doctor's shoulder, up into my vulva and my vagina. There is no reason for that.
No.
I always ask my medical assistant or the nurse who's with me to stand beside the patient.
Yes.
And to have the table up by them and to be able to hand me things if we're doing that, so that there's only one person looking at your vulva and your vagina and not two.
That's right.
Unless I ask permission first and I say I have a medical student with me. Do you mind if I show them the anatomy?
Yes.
Yeah. But other than that, no, if you have a medical assistant in the room with you, ask them to stand in front of you and beside the patient. So that really does make it feel different, I think.
It does. I agree. I completely agree. You have to be really mindful of that because, you just don't know what that patient's experience has been.
Yes.
And they're already coming in there. And like we said, we're two physicians. We're still uncomfortable and we've had kids and we've done all these things. And so it's still, like I said, I still get all like sweaty and heart racing.
Me too.
And then I laugh at myself. I'm like,
I
sorry,
stick to the paper. Get up off the table and the paper's all stuck.
It's all on your butt.
Yeah. It's horrible. So we get it. We go through all of that too.
It's fun. And then, I'm always thinking like, oh my gosh, can you please hurry up through this? It does not take that long to get whatever it is that you need to get. Cause this thing is like causing some pressure. It's going to fly out. I hope it doesn't hit you in the face.
All these things go through your head.
I do. Remember the metal speculums were the worst. I'm like, there is no way my pelvic floor can hold that metal speculum. It's like 10-pound weights. Yeah,
I agree. The plastic ones were a big move forward.
Yeah, they were. It was nice. All right. So anything last on that one? Do you want to move on?
No, I don't think so. I think we covered it all.
Okay. All right. So the second, it was still also by Dr. Sarah Signa, painful sex causes and treatments. The big takeaway is that painful sex isn't normal and it's not just in your head because women are told this all the time. Oh, it's okay. Drink some wine. They'll be fine. Or I'll have to tell you, one person that I was talking to not that long ago actually said that you must not love your partner enough if you don't want to be intimate with them.
Yeah.
I can never imagine being a clinician saying that to a patient. But these are true things, you guys, that women are told. True things. So common
We've heard the
causes.
most horrific
Oh,
things
yeah.
from our patients.
Yeah,
Yeah.
it's horrific. So it's not just all in your head. And no, it's not normal. Something that's pleasurable, it's not supposed to be painful. Okay.
Mm-hmm.
So again, I'm going to kind of go through these common causes as Aoife said before, vestibulodynia or dynia, and that is pain in that vestibule. Those could be due to hormonal issues. It could be to hyper responsive nerves is kind of how I like to say it. Your nerves are there's an overgrowth. And so if you think, I always compare it to like, shingles nerve pain. So if you're getting zingers, those are nerves that are just going kind of crazy, and a tight pelvic floor. And so, which is interesting is we can divide that into anterior and posterior, and anterior vestibulodynia is hormonally related and nerve related, but posterior pain is more muscle related. And so pelvic floor PT could be helpful with that. Pudendal neuralgia, nerve pain that worsens when you sit, lichen sclerosis. I know, we see a lot of that. And that's a skin condition causing, pain, tearing, hyperpigmentation, skin changes, usually autoimmune in nature. The big takeaway from that is that these patients can be at risk for an increased risk for vulvar cancer. So these are important to treat. And then she went on to discuss just different ways to help diagnose these, the Q-tip test. And that's what it is. You moisten a Q-tip and you gently touch. And of course, you're making sure that you are explaining this to your patient, exactly what you're doing. And you need to describe the difference between pain versus discomfort or irritation. And then again, pelvic floor exams. I don't know how many times I have done, just a bimanual exam as the second part of a pelvic and pap smear. And in nulliparous women or women that have not had babies, and I could barely do a bimanual exam because the pelvic floor muscles were so tight.
Yeah.
And I asked her, I'm just like, is intimacy painful or discomfort? Is there discomfort? And she's like, yeah, I just always thought that was normal. And so we just had this long discussion, and I ended up sending her to pelvic floor therapy and getting some vaginal dilators and things like that. And so, but
Changed your life.
Yeah.
Yeah.
Just something so simple, because she was like, no, I thought this was always how it's supposed to be. And I'm like, holy cow, the pelvic floor was so tight and so hypertrophied. Her muscles, like even over her ischial spines were just, or like those butt bones were so just thick.
My pelvis feels sore even thinking about it.
Yeah. I know.
Yeah.
Poor thing. So, so the kind of takeaway to even that segment was that sexual pain is real. It's not in their head. It is treatable. And, patients deserve that. They deserve the conversation. They deserve to be asked. And they deserve to know that there are multiple treatments for this. And, like we said, topical estrogen, testosterone mix, pelvic floor PT. I don't do the nerve blocks and things like that, but your gynecologists that specialize in this can do nerve blocks and medications or vestibulectomy surgeries for severe cases. So,
yeah. Do you know, if you're listening to this, listeners, you could open on another page, hormonally.org, and have a look at the diagram of the vulva, because we should actually just explain what we're talking about. So
yes,
when you look at the vulva and the pelvis, and you're in the position where you're about to have your pap smear or pelvic exam. So what we see is the labia majora, which are the bigger lips. Oh, do Rebbecca.
Yes. Yeah. So if you're watching the video,
the labia
You talk
majora
and
are
I
the
will.
outer lips, and they're the ones that have some hair on them. There we go. Rebecca's demonstrating. And then you have the labia minora, which are the smaller lips, which do not have hair on them. And then up at the top, we have what is called the clitoris, which is covered by the clitoral hood, which keeps it safe. And then just below there, we have the urethral opening. So that is the opening that the urethra comes from the bladder, and that's where our urine comes out of. And then below that, we have the vaginal os, which is the opening of the vagina. There's the urethra
There's
there.
that.
And then down is the vaginal os.
Out
Os
there.
is mouth in Latin. And that's the opening to the vagina. And, you know, a lot of women and lots of men do not know this anatomy. They call everything the vagina. The vagina is inside that vaginal os.
It's in there.
So when we talk about the
Right there.
vestibule, that is all the area from the inside of the labia minora in. And that is all really hormonally sensitive. If you look at it in the mirror, it's kind of pink and shiny. It doesn't have any hair on it. And it's so sensitive to hormones. So say, for instance, if you're in your 20s and you're on the birth control pill and you have been noticing pain with intimacy or even using toilet paper or anything, what can happen is the pill, when we take it, can actually cause an increase of a protein called sex hormone binding globulin. It can mop up all your free testosterone, and our vestibule needs free testosterone because we're so estrogen and testosterone sensitive. So we even have patients in their 20s who are on the birth control pill, who we have to give a little bit of testosterone to every day, and then that pain with intimacy goes away. Yeah, the vulvodynia.
And so that's the introitus, and that's sometimes that's where some of that tightness or stenosis, like it gets small, right? So it goes from, maybe it was normal and then now it's starting to get smaller there. And that can be really painful. A lot of fissuring, or, we think of tearing, micro tears in this area. I see a lot.
Yes.
And so a lot of times right in here as well.
Yes. And, women don't even realize what that is. Like, they notice that maybe once a month for a few days, they feel like they have little razor blades going on in there or small tears, but they don't look, they don't tell their doctor. And it just goes on and on for years. And what happens when we lose our hormones during menopause is this just continues on. It doesn't get better at any stage. It doesn't go back to normal. So we have to stop it at some point. And so you must
prevent it.
Yeah, you must know what your vulva looks like. So make sure you look in the mirror and examine it so that if you do it again in 6 months, you would notice any changes, because that's really important.
It is. And take away the stigma of being uncomfortable looking at your body parts.
Yeah.
Because we've always been told we're not, for women, it's taboo to, and it's so taboo that most women don't even know the names of their genital parts.
Yeah.
And so
that was a really interesting talk, wasn't it?
When it was, yes.
Women were
we digressed a little bit, but this was good.
Women were asked to draw their vulva, and
Yes.
so many of them couldn't do it. But I'm sure you could get a man. 100% of men 100%. Would be able to draw their external genitalia.
Absolutely.
And women were not able
to. My youngest can
What's
do that.
What's that about? Yeah.
It's just,
And, you see in children who've been sexually abused, there's a huge percentage of them that are unable to name their body parts.
Yes.
And you notice then a lower incidence of that in children who have not been sexually abused. So there is all these connections. Like, it's important, this education,
It's very, very
and
important.
empowers you as a girl and a woman as well.
Yeah, to know all those things. It's really important, that it is a sense of empowerment. It's taking back your body, having ownership of it, owning it. And we should never apologize for what things look like, or, for your anatomy. I mean, your anatomy is your anatomy. This is what we're born with. And so we really need to break that stigma, be proud of that. I mean, you walk into my office and I have vulvas everywhere and I have flowers that look like vulvas, and my kids come up here, they all know what it is. And so, I hope that then, as that education will continue with as my kids are having kids and teaching their children, if they choose to have children, what, the appropriate name for their body parts, and that it's not embarrassing. It's not, there's no stigma to that. It's important.
Yeah, it's time to change. That actually brings us right on to the next one, which was The Future of Sexual Medicine, again by Dr. Sarah Signa. And she was saying that finally sexual health is starting to get the attention it deserves, that medical training still is severely lacking when it comes to this.
Yes.
But that doctors are showing more interest, and there are increased positions now for sexual medicine fellowships, which were very rare and are still rare, but becoming more popular now, which is wonderful news for women.
Yes. I wish I would have had that. That would have been just really great.
Yeah. The next talk was about the testosterone debate.
Ah, yes. Do you want to take the last one? Was a little short. Do you want to take this one too?
Sure. That was by Dr. Anita Micheleni. Oh my God. I'm so sorry.
There's a couple K's and a couple N's in there. Sorry. And a couple L's.
I hope she forgives me if she ever hears that. But her talk was about educating us about testosterone. Again, so many clinicians don't know about that. Her point was that we don't realize that women make so many more times testosterone throughout their whole reproductive life than estrogen. Our ovaries actually produce testosterone. Our adrenal glands produce testosterone, and that gets converted to estradiol. It's not that we make the estradiol, it comes from testosterone. So women have never been taught this. Clinicians have never been taught this. We've all been taught that testosterone is a man's hormone. Estrogen is a woman's hormone. Not true. I remember Dr. Kelly Casperson on one of her episodes saying that they did this study on men where they blocked their estrogen and their testosterone, and they lost all their libido. And then they just gave them back the estrogen, not the testosterone, and their libido came back. So these are hormones that men and women have. And actually, if you're a postmenopausal woman and you have a male partner, the chances are his estrogen is higher than your estrogen.
100%.
That's how low it goes.
I have to start using that. I'll be like, listen, you need to calm down your E because I ain't got any.
So just really important that everybody needs to know this. And, there's a condition called hypoactive sexual desire disorder that women can have, which is directly related to their low testosterone levels. And if you give them back their testosterone, they get their libido back. And for so many women, that is really vital for them. For other women, it's not important in their life at all. And that's why you have to take it on a case-by-case basis. Yeah.
Yes.
So really,
I was going to say, because that's that whole definition of that, right? You might have low libido, but if you're like, doesn't bother me, I'm good,
then no problem.
Hypoactive sexual desire disorder. Yes. Exactly. But if you're like, I don't have my mojo and this is not okay with me and it's really disturbing, then it is. Then that's
we need to fix it. Yeah. And in America, the only kind of guidelines we have for testosterone use are in hypoactive sexual desire disorder. So if you want a trial of testosterone at any stage, your doctor is probably only going to be able to prescribe it for you if you have hypoactive sexual desire disorder. So that's where your libido is low, it didn't used to be low, and it is bothersome to you and you would like it back. And that will get you your trial of testosterone. Now, when we start our patients on testosterone, we notice some of them come back and say they've noticed other benefits. Right? I especially notice my patients who feel like they have always had ADHD, but it's gotten worse, or they've never had ADHD and now they have ADHD-like symptoms. Those women in particular find that their brains work better with some testosterone on board. Would you agree with that?
Absolutely. It's usually like, boy, I feel like the room is brighter. I feel like my mental clarity, that's what I hear a lot. And libido is better. But boy, they were really shocked about their mental clarity and ability to focus and the brain. It was the last thing that's kind of taken away the brain fog. Although, okay, we know
Yeah.
it's not used for that.
Yeah.
But I'm just saying.
I know. And like when we say this online, it gets a lot of terrible
Oh, it sure does.
lash back for some reason. And basically any of us are saying is that when we put our patients on testosterone for a reason that's in the guidelines, we notice them coming back and telling us these things.
That's right.
You know, and so medicine is both an art and a science, right?
It is.
So the
And we
art
know it.
is
Yeah.
seeing
And it's
patients and
hormones in our
listening to them.
brain. That's right.
Yes,
These things affect our brain. They are affecting neurotransmitters in our brain. So it just
exactly. Super important.
Doesn't seem like rocket science.
The last little thing she said was, to use we can either use the men's gel, 1/10 of the dose, or we can compound it. Both of those ways are relatively safe and very effective. And just to try and avoid the pellets really, or oral, the pellets, because they are so non-standardized. We don't know what's in them. Every woman reacts differently. For some women, she'll break that pellet down in 3 weeks. For another woman, it could still be sitting there in 6 months.
And what you get is what you get. If it's there and you're high, that's it. You got a deal.
If you have a problem, tough. You can't get the pellet out. And then the oral testosterone, does affect your clotting factors and can affect your liver and your cholesterol as well. So we try to avoid that. And basically that women deserve access to it. We're not asking for the world. We're asking for access to testosterone for women who would like a trial, who want to see if it makes them feel better. I don't think that's a crazy thing for women to want.
It's not. And it's kind of something that we make, and we actually make more of it than estrogen. So
don't be afraid of something your body has made for your entire life. Do not be afraid of it, because what we use to treat you is identical to what's being pumped out of your ovaries and your adrenal glands every single day. And even if you've had your ovaries removed, it's still coming out of your adrenal glands. No one's taking those out.
Nope, not at all. I don't know. There's but we did get the black box warning off, right? Wasn't that was for cardiovascular disease? For men. So that was cool. So we'll see.
How about the next one?
Oh yes, vaginal estrogen saves lives and billions of dollars. So this was Dr. Rachel Rubin.
Her talk was great.
It was every one of them.
Yeah.
I mean, she really just lit up the room, got everyone going. Urologist, sex med specialist. I mean, she's just incredible. Just the insight and the information and the advocacy and, education. So we talked about vaginal estrogen and how it can save Medicare $22 billion. The reason is because it helps prevent UTIs, incontinence, painful sex. But let's talk about the UTIs. So as women age and our estrogen goes down, then we get the genital urinary syndrome of menopause, which increases your risk of recurrent UTIs, which can lead to sepsis and can lead to death. So that costs a lot of money for women to be in the hospital and to stay in the hospital.
Yes, and nursing homes.
And nursing homes. You got it. Exactly. And so these, for just a little vaginal cream, and funny, so my 88-year-old grandma, I was just talking with my aunt about this via email just this week, and they were giving her like clobetasol and for irritation. And I'm like, she needs vaginal estrogen. Let me know what I need to do. Do I need to speak with her PCP? I can get on the call. And so, she keeps using this, and I'm just like, you've got to fix the problem. This is going to make it, it's probably going to relieve some of the changes. But now I need to find out, has anyone looked at it, at her vulva, and she needs vaginal estrogen. So
God knows what it looks like.
Right.
Right.
To be continued on that. But so this is, it's not uncommon, you guys. I see anyone who takes care of older and elderly women have seen this. These women come to you confused, or all of a sudden they are, they're septic already. So, they're being woken up by a loved one because they are not responsive, or they're acting loopy, or they're, grandma's saying something funny. It's one of the first things I check if a patient is just not talking right. And sometimes they come in talking some really weird things, and you're just like, this is a UTI till proven otherwise. And
it's unbelievable. And it's just it's not even in the bloodstream or anything. It's just a urinary tract infection.
Just a UTI
and in the bladder.
Yep.
Might not even have a fever or anything.
Never.
And your loved one is just unrecognizable, like off the walls. Yeah.
Yes. And can, from being mean to like thinking someone's coming after them. There's, they're putting money away. They're stashing money away.
Delirium.
Yes. Complete delirium. You got it.
Yeah.
And so this can, be prevented by vaginal estrogen, which is so safe. And it's so cheap. And so that's kind of what the point of that talk was. It was just that it can save billions, and because we can prevent this. This is preventable. Multiple forms of creams are of the vaginal estrogen creams, inserts, e-string. And, we again went over the debunking the myth that vaginal estrogen does not increase your risk of breast cancer. It does not increase cardiovascular disease. It is safe. I tell my patients, do not read the insert. There is a big movement of getting the black box label off of the vaginal estrogen. And if you haven't signed that, you can send a letter to that. Do you unbox menopause? I think it is, right?
Yeah. Unbox menopause. I definitely have it in my bio in Instagram.
Yeah, I think I do. If not, one of us will have that. We can always link it in the show notes as well. So it is essential. And I wouldn't just say for postmenopausal health, but perimenopausal health as well. So, we hear a lot of our colleagues say after the age of 40, you should be able to just get it and use it for prevention. So,
yeah.
Anything you want to add to that?
Just that, this is a big business, this nursing home business. These are all private nursing homes. They are so expensive. It's not like this anywhere else in the world. This is a massive business. Yeah. And our nursing homes are filled with women who have broken hips, who have had urinary tract infections or urosepsis, and who have dementia. All of the nursing homes are jam-packed with women like that. All of those things we think can be helped, or at least helped, if not prevented, with your hormones. Yeah. And to think that you could save Medicare $22 billion a year.
No, that's not just a small number.
No, by giving every woman who needs it a $3 tube of cream once a month is astonishing that wasn't put into effect as soon as that study came out.
I know it. I know it.
So that's my only addition to that. The next one was a talk by Dr. Erica Kelly, Mental Health and Sexual Dysfunction. That was very interesting. And basically, we do hopefully think like this when we're seeing patients, but sexual dysfunction usually is multifactorial. It's very rare that it will just be because you're on the birth control pill and you're having some vulvodynia because of low testosterone. That's great if that happens. But for most women, it can be multifactorial. It could be low testosterone. It could be that you're in a partnership at home and the distribution of work in the house and with kids is very different, and you don't get a break and your partner does. It can be that work is overwhelming, or that you're spread too thin. Depression, anxiety, trauma can be involved. And she was talking about, for each woman, you need to go through each of these issues and see what's involved in her sexual dysfunction. Again, very, very difficult to do unless you have an hour with a patient, right? Yeah. I mean, how do you do it? I know we should be doing all these things, and these are ideal. Hard. My God, when you're in a GYN clinic and you've got 8 minutes with a patient, how do you do this? You've got to pay out of pocket and see a sex therapist or a pelvic floor therapist. They know all this stuff as well. Or then some clinicians work outside the insurance system too. But it is really tough for women to get help that they need.
It is.
And things get missed all the time.
Yep. Oh, yeah, absolutely. The questions aren't asked. They're not comfortable bringing it up themselves. It really is that, that biopsychosocial, when it comes to desire, libido, sexual dysfunction. So, if you're in your head all the time about, oh, I don't like what I look like with the lights on. I don't like what I look like with the lights off. I've gained a little weight here. Are my smells good? Are my smells not good? How's my hair look? Do I take my makeup on, my makeup off? Are my breasts pretty? So all these things, can affect desire and libido and even just your growing up. I have patients that tell me that, when they were growing up, sex was taboo and it was, very strict. And so they have shame associated with even desiring or being intimate with a partner because it was shameful growing up. And so, there's so many aspects to this, and then trauma, of course, any type of especially sexual trauma. But, it doesn't even have to be necessarily sexual trauma, but any type of trauma can affect that as well. So it's, depression, anxiety, your sleep, if you're able to sleep, if you're getting enough sleep. So, just so many different things when it comes to sexual function.
Next one was pelvic floor dysfunction and PT by Dr. Jandra Muller. She was wonderful, and just went into, the pelvic floor muscles and ligaments and how important they are. And it can be an absolute game changer for so many women. And, if you know about it and your doctor doesn't, you can still go find a pelvic floor therapist and make sure hopefully it's covered by your insurance. This is something that's really standard in a lot of other countries, especially after having a child. You birth a baby, you go for pelvic floor therapy. You do not end up with stress incontinence later on in life where you can't bounce on the trampoline with your child because you're peeing if
or
you do.
Sneeze.
Or you can't sneeze or cough or laugh. Yeah, this doesn't happen in some other first world countries. We don't take care of our women here. So pelvic floor physical therapy needs to be, I would say most women would benefit from having some pelvic floor.
Oh my gosh. You almost should give a prescription for that as part of like their postpartum checkup, and
if we keep doing that, it's going to put demand on the system, right?
Yes.
Well, then maybe more people will go into pelvic floor PT.
You got it. Yes. Because, we just assume these women are just going to go back to normal. And I think that every woman should be given an order for pelvic floor PT.
Yes.
Everyone, and explain that, have just that explanation. If you don't have time for that, then give them the pelvic floor order and then give them the information in a pamphlet.
Yes.
So that they can understand the importance of that, because I only did it with one of mine and I wish I would have with everyone. So
yeah, we're doing better. We're trying to do better.
We're trying.
What about the next one, Rebbecca?
Okay. So the next one is non-hormonal hypoactive sexual desire disorder treatments by our dear friend and colleague, Dr. Heather Quayle.
Dr. Quayle.
She was
put
wonderful.
That whole conference together.
Sure did. Yes. Her co-chaired, I think, by Samina, Dr. Rahman. I mean, they just did an incredible job. She was running around. I wish I would have had a little bit more time with her, but everybody was taking her time. But we also did a poster presentation with her, and you did another one with her, and she did several more. And I don't know how she did it, but boy,
I don't know how either.
Pulled off a beautiful, beautiful conference. So it was just awesome. So, we talked about not every woman wants or can use hormone therapy. So what are the options for HSDD? We did talk about postmenopausal women with testosterone. FDA approved options for premenopausal women are flibanserin, or better known as Addyi, the little pink pill. This is a medication that you would take every single day. It does help you sleep. You take it at night, boosts dopamine, and reduces serotonin inhibition. And let me try and say it, bremelanotide. Did I say it right?
Bremelanotide.
Bremelanotide. Yes, bremelanotide.
The drug
My
name is
tongue
easier
twisting.
to say.
It is, I know, Vyleesi, which is an injection that can increase sexual desire. So this is kind of cool. So some women, they like to take a pill every single day, and then you have an injection, which is just used as needed. I think it takes about 16 hours, if I remember correctly, although it does not have to. Most common side effect for both of these are nausea. Addy can cause some sedation, helps you sleep. Is a little bit of a side effect too. So that's kind of nice as well. So it really just depends, I think, just on what your women want. I think even just discussing with them, most of them are not covered by insurance, of course. But
I know. So this is
there's
what I'm
coupon
looking up
cards.
here. As you're talking, I was trying to remember and Googling. So there is a website, right, where we can get help paying for Addy. I just couldn't think of it off the top of my head.
Yeah, was that the Bling RX or Blink?
Oh, Blink RX.
Blink
Anyone
RX,
who's trying
right?
to get Addy, go to Blink RX and do it through their website, because they are very helpful trying to get you money off your Addy. And with Addy, you do it for 8 weeks. You take it every single day for 8 weeks. And if it has not changed your libido, if you don't feel better on it, you stop it. You don't keep going and going for 6 months to try it.
Right. You don't have to do that.
So you'll know in 8 weeks whether it works for you or not.
Yeah.
And then if it does work for you, maybe you'll be okay, paying out of pocket for it.
Yeah.
We wish it was covered.
We wish that you didn't have to take it every day.
I know. Yeah.
I'm like, give me the pen. I just want to use it when I need it.
Yeah. The pen is for when you want it. The first couple of times it can make you quite nauseous. So we normally give it to you with a medicine called ondansetron to stop that nausea. And you do a trial run with it as well to see how long does it take to kick in for you. So when it's date night, I need to take it 6 hours beforehand, or I need to take it 30 minutes beforehand.
Yeah.
So you kind of do a trial run as well, once or twice. An expensive trial run, right? These medicines are pricey, unfortunately.
Yeah, they are.
Much easier for men to get their 25 different sex medicine options than it is for women to get their 2 options. Yeah. Very expensive.
Just saying.
Not a fault of the people who invented it, I think, but more to do with insurance coverage.
Yeah. So there were a few off-label options. I don't know. Have you used these? I mean, maybe Wellbutrin. I think I haven't used Wellbutrin solely for that. I usually tell them, though, if it's a woman that I need to start Wellbutrin on, I do let them know that it could help with their sex drive or not deplete it like some of the SSRIs. And Buspirone, that was a new thing I learned too. I use Buspar all the time and for anxiety, but I don't know that any of them have come back and told me that the libido is.
I am the same, Rebecca.
Okay.
I use it all the time. I absolutely love it. When I was taught about Buspirone or Buspar, I was told, it's got a very low kind of success rate. I have found the complete opposite.
Same. And men and women.
Love it. And they don't complain of any side effects.
Nope.
It's very well tolerated.
Extremely.
Very well tolerated. The bupropion or Wellbutrin, I would use mostly when I have a patient who's on an SSRI, like for depression or anxiety, and when they started the SSRI, they noticed a drop in their sex drive. And then sometimes if you add in the Wellbutrin, that can help bring things back to normal. So I
usually would just switch it.
Yeah, I absolutely hate treating one side effect of a medication with another medication. It seems to have become so normal. And every time someone mentions it, I'm like, ooh, like we were never taught to do that. What are you talking about? Treat a side effect
why don't
with
we
another
just
medication.
Change it?
Exactly.
I'm
but
like,
if you had a patient who was like, oh no,
weird.
I love my citalopram. I don't ever want to change it. And then I would say, okay, well, then we can add in Wellbutrin.
Right.
But otherwise,
100%.
you want to take the person off whatever is causing side effects.
Hey, we could try this. And it has, it's good for weight, those like few pounds.
Yes.
But so I think the key takeaway that, there are multiple treatment paths if you are choosing not to do hormone or you can't do hormone replacement or can't do testosterone. and again, we'll go back and mention too that testosterone, we give it 6 months. And if that doesn't work either, then we don't continue that.
Yeah. If it hasn't worked by 6 months, you can come off it. What's last? It's Dr. Heather Howard, Sexology and Sex Counseling. Oh, yes. She told us about this PLISSIT model. So it's PLISSIT. So P is for permission. So these are things that you talk to your patients about. And she's a sex counselor. So you give your patient permission to talk about sex, because for many people, especially anyone religious, it's usually connected to a lot of shame and guilt and something that's very taboo and not talked about. So first of all, you give your patient permission to talk about it. The LI is limited information to educate the patient. So you don't fire information at them. You pick out what might be helpful for them and you give them that information. And then when you guys work on all of that, you can come back and address something else, but you don't try and address too much at the one time, or it's overwhelming. The SS are for specific suggestions for improvement. So if there is something helpful that you can say when you're doing sex counseling, do say it, in the hopes that that will be like a little nugget that your patient can take with you. And then the IT is it says intensive, presume it means intensive therapy when needed. So, just to kind of base the frequency of counseling on what you feel your patient needs. So that's PLISSIT, the PLISSIT model, which was interesting. I don't think either of us had come across that before, had we?
Nope. No,
it's
I thought
nice
that was
to hear
really
from
great.
Other specialties and learn this stuff.
It was.
Yeah.
And I like, that big takeaway with that again is, all as with all of this is it's that the sexual dysfunction isn't just physical. Therapy and counseling are big. It really takes a team. That was kind of what I thought. It was almost a key takeaway from the whole conference is it takes a village, right? It isn't just one. I loved that. It was therapists and pelvic floor and, and then your GYN and your primary care. And, so there was just a whole just group of, your team, and don't be upset if you don't find one person that can help with all of these things. It takes a team. We are learning that it's just too much for one person to do, for your internist to do, for your primary care to do, for your GYN to do. It really is a team approach. And I, quite frankly, really love it. I love working as a team and getting, new ideas, new approaches, help with patients. And, so your nutrition therapy and your sex education, your sex therapist and your couples therapy. And so I just think I'm hoping that this is where medicine is moving forward with this team approach. And we just are really caring for patients a lot better.
Yeah. So I'll go to key takeaways from today.
Yes.
So I think I'm going to narrow it down to maybe 4 things. So first thing I would say is look at your vulva. Get a hand mirror, sit on front of a long mirror, whatever you want, and look at your vulva. This might be the first time you ever do it, but I think it's probably a good idea to check every 6 months or once a year, especially if you're in your late 30s, early 40s. This is when you're going to start getting those hormonal changes. So don't be afraid. Look at your vulva and identify the parts. Go to hormonally.org and look at the diagrams. They're so helpful. The second thing I would say is when it comes to your pelvic exams and your pap smears, think about what we mentioned there, how if possible to take a little extra time to do some deep breathing, center yourself, talk to your doctor beforehand, tell them you're a little bit nervous if you are, or tell them about any kind of trauma you might have had in the past, if you feel comfortable doing that. And if there's a medical assistant there helping and they're standing looking over the doctor's shoulders, you can feel that's okay to ask them to move and come and stand beside you. They don't need to be looking at your vulva to help the doctor. Number 3, I think the vaginal estrogen was really important. So to know about it and what it does, and not to be scared of that label with the old black box warning in it, which is not accurate information. And then the last thing that you brought up just there about it taking a village or that team approach, I think that's really important, in that, just speaking to any clinicians listening, you do need to know about all of this, but you don't need to know how to treat everything. So if you come across a woman who's complaining of low desire and you're not sure where to start, maybe start by referring her to a pelvic floor therapist who can have more time with her and get more information, send you back a clinic note saying, I think this woman might benefit from testosterone or something else. Yeah. And then you've started the ball rolling, which is really all the patient wants. She wants to feel heard and that someone is helping her. And the final message being, sexual health is health. It's time we start treating it that way.
Absolutely. All right. Well, thanks for tuning into the Dusty Muffins. Follow us for more midlife health, menopause, and sexual medicine conversation. Rate and review us wherever you get your podcasts. And until next time, stay informed, stay empowered, and keep advocating for your sexual health.